Hey guys, good morning.
Well, good morning, good afternoon, good evening, wherever you are in the world, whatever it is that you were doing before. It's an absolute pleasure that you've given that up to join us, to meet with us, to talk with us, and to share some thoughts about what an extraordinary year we've just come through, and to pick up on the key learnings that I think all of us have made in the last year of COVID-19 pandemic. My name's Ian McInnes. I'll introduce my co-faculty momentarily, but a couple of housekeeping remarks. First of all, if you're an attendee, you're going to be on mute, and we're going to have questions and answers here, so please do feel to put questions in at the end of the webinar for the Q&A session so that we can really give our faculty a hard time. As always, the rules are simple. If it's a hard question, I'll ask the faculty. If it's an easy one, I'll attempt it myself. Now, throughout the webinar, if you have any questions or experience any technical difficulties, use the Q&A box, and our wonderful technical team in the background will keep everything all in order for you. And the other thing to say to you, rather importantly these days, this is a meeting that is UMS ACME approved for 1 European CME credit, so you'll receive a certificate of attendance via email after the event. Okay, so, well, what else have we had to talk about for the last year other than SARS-CoV-2 and the disease state that virus incites, the COVID-19 state? And I have to tell you, it's been pretty momentous for us in all the medical disciplines. And I guess in rheumatology, it's really struck home. This is an infection-induced systemic inflammatory disorder, which has some resonance for us, I think, as rheumatologists. My name's Ian McInnes. I'm Vice Principal Head of College in the University of Glasgow. I'm also President of EULAR, although I don't sit here with that office in mind at the moment. And I'm really delighted to welcome you to what I know is going to be a really interesting, a stimulating and informative webinar. Why do I know that? Because we've got such fantastic faculty to lead, to educate, and to entertain us. A real pleasure to welcome John Beigel from NIAID in Bethesda, Maryland, in the United States. He used to be based in Building 10 at NIH, those of you who know that beautiful campus, but they sent him off to some side house, he said, a little hut they built for him in a special car park somewhere. Anyway, John can defend himself later, but John, it's an absolute pleasure having you joining us. We've got a lot to learn from you, and I'm looking forward to that very much. We're joined also by Kevin Winthrop from Oregon. Kevin, thank you for getting out of your bed so early this morning. I don't know whether you've been out surfing or down on the beach or just whatever it is you Oregon people do this early, but thank you for making the time to be with us and for once again educating us. And finally, turning to Professor Rike Alten, a very dear friend and fellow European rheumatologist from the University of Medicine in Berlin in Germany. Rike, welcome, hardly needing introduction to this audience either. So fabulous faculty and great things that we're only going to talk about. Now, just to say that we are happy to make the following disclosures, but the content is ours. We take full responsibility for what we want to talk about and why we're talking about it, but it's important that you know that these are background relationships that exist. So what do we want to learn in the next little while? We'd like to think about how our knowledge of the virus has evolved in this extraordinary year. We'd like to think about how treatment of COVID-19 has evolved. And we're going to particularly focus on some of the therapeutics that have been derived, I think, from the rheumatology community. And the reason for that is I'm sure you've been like me, you've been asked questions by your infectious diseases colleagues, your ICU colleagues, about medicines that to us are very familiar, but to them perhaps a little less so. We're also going to think now about vaccines and what that potentially means for us as we hope this pandemic comes towards its conclusion. And of course, we're going to think a bit about influence in rheumatologic practice. This is our agenda. The times given here are Scottish times, but if you do a little bit of adding or subtracting wherever you are in the world, that will hopefully tell you roughly where we are. At 10 past the hour, we're going to bring John in just to start, and then 20 minutes after that, Kevin will join us, and then 20 minutes thereafter, Rika. And as you can see, we put quite a few minutes at the end for questions and answers. So please do remember to put those questions and answers in as we go, because we're very keen to direct them to our expert faculty. And just a couple of final remarks before we launch into the business of the webinar. I thought I'd start with Charles Dickens, and these are the opening words of his truly classic novel, A Tale of Two Cities. It was the best of times, the worst of times, the age of wisdom, the age of foolishness. The epoch of belief was the epoch of incredulity, season of light, season of darkness. And maybe I should have stopped to say it was the spring of hope, because that is indeed where we are, a spring of hope. But if you think about that, there is the incredulity. More than a year ago, could we have imagined the societal, the health-related, the personal events that have befallen us all? I remember back very well, just after New Year's Day. Well, it's a New Year celebration in Scotland, so I'm not sure that anyone remembers life very well immediately after New Year in Scotland, but my recollections are pretty firm of the first knowledge I had of this mystery illness caused by a coronavirus. That medical guru, the BBC website, we go so often now to the media outlets for immediate knowledge. And the idea that there was going to be an enormous change ahead of us, and everything did change, except perhaps not everything. Osler, of course, that great medical educator, you will draw from your errors the very lessons which may enable you to avoid the repetition. And my goodness, we've learned so much in this last year. And that's, I think, one of the key learnings for this webinar. We'd like to reflect on that which worked, reflect on that which did not, and think about how on earth human innovation has really delivered so remarkably in this molecular medicine age to support society. And so, ladies and gentlemen, I want to start in a timely manner. It's an absolute pleasure to introduce John Beigel, hand over control of the slides to you, John. I'm really looking forward to learning from you and listening carefully to what you have to say. Welcome, and the floor is yours, sir.
Perfect. So thank you for the invitation. Let me just... There. So thank you, Ian, and thanks to the organizers for the invitation to talk. It is my first time talking at a forum quite like the Cytokine Signaling Forum. And if you had to ask me 2 years ago, in 2019, what's the relationship between the drugs that target cytokines, the drugs you're used to, and respiratory viral disease, the field I'm used to, that discussion would have been talking about how drugs are risk factors for acquiring disease, how they're risk factors for severe disease, but we would never be talking it in the realm of therapeutics. But in 2021, everything has changed, and these drugs are key components to the treatment of COVID-19. So it just shows the limits of our knowledge about respiratory viruses, the inflammatory state, and how these systems work together. So the approach I'm going to take over the next 20 minutes is to talk about two things. Talk about antivirals. The focus early in the pandemic was about antivirals, and talk about Remdesivir, which is the primary antiviral available. And then discuss the anti-inflammatory approaches. And there's more information about the role that inflammation has in this disease. And so I'll talk through Dexamethasone, Baricitinib, and Tocilizumab. So let's start with Remdesivir. So early in the pandemic, all thoughts were focusing on developing effective antiviral strategies. So we quickly developed what we call the Adaptive COVID Treatment Trial Act, ACTT-2 where we studied hospitalized adults with SARS-PCR positive, evidence of lower respiratory tract disease. That could be by hypoxia, infiltrates, mechanical ventilation, oxygen requirements. And then they were randomized to Remdesivir or placebo up to 10 days, and it stopped at the time of discharge. In order to understand how to evaluate the drug, we came up with an ordinal scale, and we've used ordinal scales in other studies. And the idea is fairly simple, that these are unique spaces that represent categorical improvements and you can't occupy more than one of a space at a time. So it makes it really easy to assess where a patient's at, really reproducible data. And in the middle of a pandemic, we're thinking, what is an accurate way to measure outputs without collecting a lot of data? So the Ordinal Scale is from death, which is 8, all the way up to not hospitalized, no limitations on activities. To come into the hospital, to come into the study, it was one of the 4 categories highlighted in blue. So hospitalized, but the full spectrum, because we didn't know what groups would best benefit from this. So not requiring oxygen all the way up to mechanical ventilation or ECMO. And then we defined our primary endpoint as time to recovery, which all that means is getting up to one of those gray categories. So the top 2 are out of the hospital. Category 3 is hospitalized, but not needing to be hospitalized. They're not on oxygen. Therefore, infection control, placement issues. Sometimes people were evacuated from cruise lines to the middle of the country and they live on one of the coasts. So there were just delays in getting them home, and they were still in the hospital, but didn't need to be in the hospital. So from the ACT study, we enrolled a total of 1,062, about half in the Remdesivir, half in the placebo arm. And the time to recovery for the entire group, 10 days for the Remdesivir arm, 15 days for the placebo arm, recovery rate ratio of 1.29 and a nice small p-value of less than 0.001. And when you break that down to say who really benefits, what we have is the ordinal score at baseline. So which of those 4 categories did they come in? The overall you've seen over on the left, and then by each category, we've got it broken down. So you see the majority of the benefit is in those not on oxygen, those on low flow oxygen. Those on high flow oxygen, those on mechanical ventilation, we didn't show a benefit. If you look at the high flow oxygen, the numbers are small. It goes from 19.5 days down to 15 days, but a recovery rate ratio of 1.09. Mechanical ventilation, this was a 28-day study, and you see the median time is 29 days. So we completely underestimated how long we needed to follow up to get a meaningful outcome in that group. I mean, this is what happens in the beginning of a pandemic before you have clear outcome data in which to structure trials. So we didn't show a benefit, and you see the recovery rate ratio of 0.98, that group didn't benefit enough from Remdesivir to show improvement of the median time to recovery. The mortality, we had a hazard ratio of 0.73, so a decrease in mortality, but it wasn't significant, a p-value of 0.07. Again, what you see is the benefit is best in the, here being obviously below 1 is what you want. The biggest benefit in mortality was the group that, again, not on oxygen or on low flow oxygen. The totality mortality went from 15% down to 11%, but you see a very different depending on the severity of illness at patient presentation. So we looked at a variety of different secondary outcomes, and we showed benefit in days on oxygen, the amount of new oxygen use, the amount of new mechanical non-invasive use, the amount of new mechanical ventilation use. You can look down and you see benefit to the Remdesivir. All of these are secondary outcomes and not corrected for the multiple comparisons. So we don't tend to report p-values, but you see that they all support the story that we showed with our primary outcome. So after we were finished, the WHO started their Solidarity trial. Actually, they started before we had published, but the majority of it started after we had published. The Solidarity trial is a trial in hospitalized COVID-19, and it looked at a number of repurposed antivirals. I'm just going to focus on the Remdesivir. It is designed, it's a very different study. It's a what I would call a simple study, which is designed to look at large numbers, to be able to implement the study anywhere, and there's values in that, and with a really simple data set. So they evaluated them at the time of consent, they evaluated them after death or discharge, and they never needed to see the patient again. They could just evaluate via the chart. So basically, what study drugs were given, whether mechanical ventilation or intensive care was used, and the date of discharge with the date of death. That's the information that they collected. And they implemented this big. It was a big study. The 11,000 people randomized 2,700 to the Remdesivir part of this study. And in that study, they showed the Remdesivir and its control arms right on top of each other. In fact, most of the interventions they had were right on top of each other and were not able to show any benefit in mortality from Remdesivir. It's a simple study, and I think we need to be honest about comparing the data. It doesn't have placebos. It didn't require any confirmation of COVID infection, or at least that wasn't documented. People needed to stay in the hospital course for the treatment course. Investigators were allowed to choose what they considered acceptable therapies, and I think you see that by the Remdesivir arm had mortality of 12.7, the hydroxychloroquine, the control arm, had a mortality of 8.9. The inclusion criteria for renal and hepatic impairment is really the same for those. So there's really no reason except that people were shuttled into one arm or another. And they had really high mortality rates of 43% on the vent, where we had a mortality rate half that at 22% on the vent. So I don't think one is better than the other. I think you have to look at them together. So I would say Solidarity doesn't negate ACT. I mean, some people have implied it does because it's a bigger sample size. Bigger trial with more uncertainty is not necessarily better. ACT doesn't negate Solidarity just because it's blinded, just because that we collect more data and we have true randomization. I think you have to look at the totality of the data. So it's reasonable to say, was ACT the outlier? And I think we have to be open to it. And we don't work for Gilead, and we have to be open to the idea that maybe we were the outlier. But there have been a number of studies, and here's one that I picked that looked at an observational studies. So this was observational, lots of limitations with that. It's a retrospective observational study that looked at clinical improvement with or without Remdesivir. And what you see is similar numbers. Now, they define clinical improvement slightly different than we did, but you see a hazard ratio of very similar numbers to what we had described in ACT. So I don't think ACT's an outlier. At least this was done in the Baltimore, Maryland, Washington, D.C. area, and maybe the outlier is more the support that we can provide with Remdesivir versus the sites that Solidarity was implementing. So what I would say is when to use Remdesivir, I think it's Remdesivir is indicated in those hospitalized with COVID-19. I don't think there's sufficient data to know which groups. Those not on oxygen will likely do well with or without Remdesivir. Remdesivir might prevent some deterioration. There's some secondary analysis that suggests that. I think those on oxygen, high flow oxygen, non-invasive clearly benefit from Remdesivir. Those on mechanical ventilation may not. I mean, we couldn't show it, although the study wasn't designed, as I mentioned. So does Remdesivir improve mortality? I think we have to be honest, and the answer is no. There's currently no data to support mortality benefit. Is Remdesivir effective for treatment? And just because it doesn't benefit mortality, and I think the answer is yes. It's faster recovery, less days on oxygen, less time on event. In the middle of a pandemic, all these resources are important. Can we do better? Sure. I mean, this was not the home run we wanted. This was a significant improvement, and I think we can do better. And I think over the next few months, we will see much more data about monoclonals and other antivirals. So switching to the anti-inflammatory strategies. So early on, this sort of paradigm of viral response and host inflammatory response was proposed, and the remdesivir is sort of right in that middle. That's what we studied in that group that was short of breath. But then there's the question of the host inflammatory responses and how to approach that. So let's first talk corticosteroids. The recovery study was the big corticosteroid study. I'm sure everyone is familiar with 176 sites in the UK. It was a simple study design. They randomized to a number of different arms, and they also had the one documentation at death or discharge where they collected some clinical data. So again, designed for large implementations. And with that, this is their primary outcome, which was mortality. And they showed a drop in mortality down from 25% down to 22%. So about a 3% improvement in mortality, but with really big sample numbers, and gives you a fair amount of assurance that this is real, and a p-value of 0.001. Now, what you see is that the subgroups where those on mechanical ventilation did the best. I mean, that's the top row. The boxes furthest to the left, those not on oxygen are on the wrong side of one. There's potential for harm, although the confidence interval is wide enough that it crosses one. The recovery study is not the only study, and just to kind of show the heterogeneity in the field, though, this is one of the meta-analysis. There's multiple meta-analysis out there. The top 5 rows are randomized trials. The rest are observational studies. And there's a fairly consistent message. You see a number of the randomized trials had smaller effects than the recovery trial. They cross one. But for the most part, things are leaning to the left. And they have an odds ratio of 0.84. Some of the observational studies suggested harm, but I think I would put more credibility into the randomized studies at the top. So for corticosteroids, I think dexamethasone improves outcomes. The largest benefit is those on mechanical ventilation, maybe some harm for those not on oxygen. I think we need to be aware of that. Significant heterogeneity in the results. So I think there's still more work that needs to be done about defining the groups that benefit, and there's no data to suggest corticosteroids are a benefit in outpatients. So let's shift now to baricitinib. It's a drug that this group knows well. It's a JAK inhibitor. We studied it in ACT-2, and it was very similar to design to ACT-1, hospitalized with the same inclusion criteria. And we started prior to the recovery trial. So we started on a a group that had minimal amounts of steroids. And this is our primary endpoint for that. This, again, is looking at time to recovery. Time to recovery goes from 8 days down to 7 days, 1 day improvement of recovery. Just for comparison, that's the recovery trial had a 1 day improvement in hospital length of hospitalization. So similar treatment effect size, much smaller study, recovery rate ratio of 1.16, big enough that it did have a p-value of 0.35. If you look in this group, the group that seemed to benefit the most is those on low flow or high flow oxygen, this category 5 and category 6. Category 4, not on oxygen, again, similar to steroids, is on the wrong side of 1, but a fairly large confidence interval. And we didn't see, unlike corticosteroids, there was no benefit in those on mechanical ventilation. Mortality goes from 7.8 down to 5.1, so similar absolute mortality benefit to what was seen in recovery. And again, the biggest benefit in this is the low flow, high flow oxygen groups in the middle here with hedge ratio 0.4 and 0.5. So putting Dex and Baricitinib side by side, you see that the numbers are actually fairly similar. So the setup here, Act 2 at the top, which is the Baricitinib Dexamethasone recovery trial at the bottom. The absolute mortality benefit changes in about just shy of 3% in both studies. It is a slightly larger benefit in those on oxygen in the Baricitinib trial. And in the recovery trial, you saw the main benefit in those on mechanical ventilation where you didn't see any benefit with Baricitinib in that group. So I think there's probably some balance here where those on mechanical ventilation benefit from the biggest immunosuppression, which is the steroids. The more subtle immunosuppression maybe is more beneficial for those in the middle. But these are not directly comparable studies. So until there is a study, which we're doing a head-to-head, that we can't really make too much out of this comparison. So how would I wrap up Baricitinib? I would say Baricitinib improves outcomes. It shows effect size similar to dexamethasone. We did not demonstrate mortality benefit, however, and I think that's the reason dexamethasone has been widely adopted. And they might have benefit in different subgroups than the dexamethasone. And again, really no benefit in the no data to suggest benefit in the outpatients. Let me just shift quickly to the tocilizumab. So this was also studied by recovery. That's been studied by a number of groups, but recovery is the big one, where they looked at a group that was hypoxic and had a CRP greater than 75, and then they were randomized to standard care or tocilizumab and the same sort of recovery design. And here they showed a very nice, again, separation of the curves with a very nice benefit of tocilizumab that suggested a mortality benefit and a recovery rate ratio of 0.86. Now, the recovery has tocilizumab has had multiple different studies, and this is a meta-analysis looking at those, and this is even more heterogeneous than the dexamethasone. A number of large studies, well-done studies that suggested harm from tocilizumab. So there's a very heterogeneous results, and what I plotted on the right is looking at the results based on control arm mortality. And when you get a control arm mortality of 30–40%, and you saw that in REMAP-CAP, you saw that in the recovery trial, that you see benefit, but when you get to the much smaller mortality, that benefit seems to go away based on the totality of this data. So how would I wrap up tocilizumab? I would say tocilizumab may improve outcomes in those with COVID-19 in select populations. It's the recovery study was done on top of dexamethasone, so the benefit is mainly in those already on the dexamethasone, mainly in those that have the most inflammation, and recovery defined that as a CRP greater than 75. But at the bottom bullet, I think additional studies really are needed to understand who benefits from the tocilizumab. So how would I wrap all this up? I think dexamethasone, corticosteroids likely beneficial. I think there's a fair amount of data to support that. They might not have benefit in those not on oxygen. There's no data to support treatment on an outpatient, but for those on oxygen up through mechanical ventilation, I think there's a benefit. Baricitinib is an alternative to corticosteroids, probably best used when corticosteroids can't be used or not preferred. There are some unique groups that baricitinib seems to work better. Toci is maybe used for those at high risk for poor outcomes. I think we still need to figure out how best to define that. And there's a multitude of other anti-inflammatory interventions, really small studies that I didn't have time to study, time to review today, but the benefit of those still, I would say, needs to be determined. So just in conclusion, this is sort of how I would wrap up the landscape, if you will. The blue, again, is the antiviral response. Remdesivir in the middle has a clear benefit. Monoclonals I didn't talk about, but they haven't worked inpatient. They have worked as an outpatient, so early in the disease before they're hospitalized monoclonals. The dexamethasone mainly to the far right, and the most inflamed group. That Baricitinib might have a sweet spot in the middle. And Toci, I tried to shade with a slightly different pattern to say it probably works, but I don't think you can use the same analogy and say it's a stage 3 or it's a group on the vent, and we need to really think about how to define that special, that patient population. And then those in clinical trials, this is just what I would anticipate at the bottom. Antivirals are going to be the most benefit the earlier we can get them. Oral antivirals are being studied, and I think that's the appropriate approach. And then anti-inflammatory strategies, probably the further inflamed you are. So with that, I will close. I apologize for running over just a little bit, and I think we'll take some questions.
John, there is no apology needed. That was really beautiful. It was clear, it was comparative, and it offered us that critical acumen, which is just so valuable when you're actually telling us about the data rather than allowing us to read them alone. So thank you for that. There are no burning questions other than one that I just want to ask immediately before we bring Kevin in. These meta-analyses are very interesting to me and are clearly weighted for larger number trials as opposed to small ones. And the impact of relative risk in the control arm is a really elegant description of trial design impacting decisions that can arise out of it. I mean, let me be gently provocative. Do you think we should be doing small trials in the COVID era, or is this the moment for really large, properly controlled, systematically organized, multi-center studies? Is that the age that we've now entered for this kind of pandemic response?
Yeah, I mean, I think it's a very important point. There have been a number of small studies that have been done to the point where sites are being overwhelmed by pharma companies fighting for the patient population. And so I do think that to some degree there's been a disservice by the number of small studies we've been doing. I think there's still a benefit of what I would call reasonably large, like ACT. I mean, 1,000-person study is it's a reasonably large study for an infectious disease study, but we collect a lot of detailed information, and there's some data where we can actually see how remdesivir is working, of whether it's improving outcomes or preventing deterioration, and how people move through the treatment course. I think there's value in detailed information like that, and detailed safety information like we would collect in ACT. And then there's definitely value in the large, simple studies. And we could never do an 11,000-person study and collect the amount of information we collect like we need for a new drug like remdesivir. So I think there's still value in the moderately large studies like ACT, the large, simple studies like Solidarity, like Recovery, but we need to do better at minimizing some of the really small studies that seem to cause more noise than true signal.
Yeah, that's a very elegant answer, and maybe something we'll come back to as we enter our Q&A session later. John, thank you. That was fabulous. So from one great speaker to another, Kevin, it's an absolute delight to welcome you. Thank you for joining us this morning. Kevin Winthrop is Professor of Infectious Diseases, Public Health and Preventative Medicine and Ophthalmology in Oregon Health and Science University in the United States. Kevin, if you click on the screen, I believe you have control of the slides, and we're looking forward to hearing what you have to say. Greetings, sir.
Hey, Ian, thank you for having me, and it's nice to see you and our other friends and colleagues here, so thanks. I have 20 minutes and even less to bring you up to speed as to where we are 1 year in, roughly, to talk about vaccines specifically, so I'm just going to launch right into it. This is the graphic that everyone's seen about 1 billion times, the little spike protein, the graphic of the receptor binding domain. The point is that there are a number of vaccine candidates that have now advanced. We are obviously using some of them. The platforms used have been numerous. We have the new mRNA vaccines, of course. There are DNA platforms. There's recombinant protein vaccines, inactivated vaccines. There's even live attenuated vaccines still out there in the pipeline. And then, of course, the vector vaccines, antiviral concepts. So I'll go into a little bit of each of these, or at least the ones that we're using currently. But this has been a remarkable year of vaccine development. I think none of us thought it could proceed so quickly and produce such efficacious vaccines. I think most of us thought we'd end up with flu-type efficacy vaccines in the 50 to 60% range, and here we have vaccines that are 90% effective. And so we're pretty pleased. And they were done. The development programs were done appropriately with large numbers of people. Trying always to reassure my patients that no corners were cut here. These were typical vaccine development programs that just were run at higher speed due to the pandemic. So to give you a flavor of some of the vaccines being used, so this is the Pfizer mRNA vaccine. This is very typical immunogenicity data from pretty much all the vaccines that have published their immunogenicity data so far that have looked successful anyway. These are older individuals, and you can see on the right side of the screen, the 30 microgram dose was the dose that was taken forward. This is an examination of neutralizing antibody titers. So day 1, the vaccine's given. You can see day 21 is the booster. Not much is going on yet in terms of humoral immunity, but by day 28 and day 35, 1 and 2 weeks after the booster, we see large increases and robust increases in neutralizing antibody titer. And the point that they make in this paper and in all the vaccines that have published their data, that the level of neutralizing antibody titer is similar to or higher, in most cases is greater than what is seen in a selection of convalescent plasma from COVID survivors. So the hope and the idea is that we're producing at least similar immunity to the natural infection and probably more robust immunity that may in fact last longer. I mean, that's what we're hoping. In terms of cell-mediated responses, again, most programs have this type of analysis. These are reactive CD4 cells and CD8 T cells. You can just look at the CD4 T cell response on the left here with the 30 microgram dose. But again, you see start and then after the booster, you see this rise in cell-mediated responses. These are activated CD4 cells in the presence of spike protein. And you can see compared to the healthy controls, or again, these are COVID survivors, you can see that the levels are, again, similar or to a greater extent in terms of cell-mediated immunity as compared to the convalescent serum. In terms of phase 3 data and efficacy data, most of you have seen all this, although there's a little new data with AZ just recently. But the Pfizer vaccine, of course, initially reported a 90% efficacy. They've more recently reported a similar level of efficacy that's been maintained now approximately 6 months in or at a 6-month time point. Moderna, similar efficacy, 94%. The AZ vaccine is worth talking about. I'll mention a little bit about the coagulopathy later. This has been an interesting ride with AZ. In the UK, of course, you guys have relied quite a bit on this vaccine to date. The data looked great in the UK. It was about 90% efficacy, but of course, the dosing wasn't done correctly there in the trials, or in many places there was a half dose given by a full dose. And it turned out to have a greater efficacy than what was done in Brazil, which was really the full dose given first, followed by the full dose, and the efficacy was 62%. Now, the US phase 3 interim results, they're not interim, they just finally reported them. They reported them as 79% efficacy just a few days ago. And of course, the DSMB, you probably read in the paper, went wild and they argued back and forth, and then AZ re-released a press release a few days later and dropped it to 76% efficacy. So The efficacy is a little lower here. Of course, it's a little more difficult looking at efficacy data the later we go in the pandemic. There, as you know, there are more variants out there. Some of them don't probably aren't covered as well by the vaccine, and that's been shown in some of the other larger trials that have had South African representation primarily, and I'll get to that here in a second. In terms of reacto, the younger you are, the more reacto you have. If you've had COVID before and now you're getting vaccinated, more likely to have more reacto. Reactogenicity are really those vaccine-related events in the few days around the time of vaccination, mostly sore arm. You can see here, fatigue, headache, chills, joint pain, muscle pain. A lot of these things are not uncommon, mostly mild, sometimes graded as moderate. And more common than after the second dose as compared to the first dose. These are the percentages in the patients who mimic more your rheumatology patient age group, 55 and up. But like I said, these are more common in younger people who have more robust immune responses to the vaccine. But I will say that all of these resolve. I mean, this reactogenicity should not be something that keeps someone from getting the vaccine, but you might. I had a patient ask, maybe I should get it on Friday. So if I don't feel good on Saturday, at least, I won't have to call in sick to work. And I said, I'd actually get it on Sunday so that Monday you can call in sick to work and not go. Anyway, it depends how you look at it. In terms of the adenovirus vaccines, again, very similar data. This is the chimpanzee adenoviral vaccine construct from AZ. Day 0, day 28, day 35. So after vaccination, and this was with a prime and boost strategy, you see this rise in neutralizing antibody titer. And again, they make the point that the levels of neutralizing antibody titer are similar to what's seen in the convalescent plasma samples from COVID survivors. And again, similar to what I've shown you before. The same would be true for the cell-mediated immunity. They have both a prime here in the middle and then a prime boost strategy. Both showed the ability to increase measures of cell-mediated immunity as measured by ELISpot and activated PBMC. So what are moth cells are good for? I have these moths, actually. This is a fall armyworm moth. They eat my sweaters. But they're also remarkably adept at cranking out spike proteins. So this is the Novavax program. They used a baculovirus and they inserted spike protein DNA into that virus and they infected these moth cells with the baculovirus. And the moth cells just crank out spike protein after spike protein that then get put together in this little synthetic particle. And then they get married with saponin, which is an adjuvant which you're all familiar with because it's very similar to the adjuvant used in GSK's Shingrix. It comes from the soapbox tree, which is a Brazilian tree originally. And anyway, this is a very powerful adjuvant, as you know, and you put these things together and you provoke a robust immune response. They have very similar data to the data I just showed you before. If you look at the middle here, this is the vaccine plus the adjuvant. But again, you see a very large increase in neutralizing antibody titer between 0 and 21 days, but even larger between 21 and 35 days. And again, the same point here is similar to or greater to what's seen in the human convalescent serum. So phase 3 results continued. Johnson & Johnson, their one-shot, no deep freeze vaccine, easy to use. We're using it in the US now. 72% efficacy in the US, so a little lower. They were able to show that there is an influence of the South African variant. They had a substantial chunk of folks in South Africa. The efficacy was a little bit lower there, and it was primarily due to two factors: HIV, number one, but more so, much more so, primarily the fact that a good chunk of these people had the South African variant, which does not seem to respond as well to these vaccines. Novavax reported the same thing: 89% efficacy in the UK. Their US data is still pending, but again, a lower efficacy in South Africa due to the strain present there. In terms of durability, Moderna published recently a nice paper looking at the length of immune response durability, and it looks quite durable. You can just read what's circled in the bottom there, but at 4 months, they were still showing neutralizing antibody titers that exceeded that of what was seen from COVID survivors. So, 4 to 6 months plus, we're seeing measures of both humoral and cell-mediated immunity maintained to a reasonable level. So the variant strains, I don't have time to get into all of them, but the South African one is of most concern, and that is the one that has been shown to be less responsive to both monoclonal antibody products as well as patient samples from vaccinated individuals with most of these vaccines. Now, how did the vaccines do against these? Well, I just told you that there is some diminished efficacy, although at least with the mRNA vaccines, we don't know that. This was an analysis published using the Pfizer vaccine. Actually, these were patients vaccinated with the Pfizer vaccine. You can see some diminishment in the neutralizing antibody titer here. This is the South African, the lowest bar there, the fourth one from the left is the South African strain. So you can see some diminishment, but overall the titers were still quite high, and there's likely good protection still offered by the vaccine. And I think even the J&J vaccine and Novavax vaccine that showed lower efficacy, again, still decent efficacy, 60%-ish in that range. So there is still activity, but of course we worry if more mutations occur, potentially they could change that game. So what do we know about other vaccines? I'm just going to roll through this because I don't have tons of time, but TNF blockers generally don't diminish the proportion of patients reaching a protective level, at least not with influenza vaccine. But you can see these dotted lines here are the lowest. These are the TNF users as compared to the solid lines, which are higher. So when you look at absolute titers, the people on TNF blockers do have lower titers. You see the same thing in HBV. You see lower rates of protection and decreased quantitative titers of hepatitis B surface antibody after vaccination in patients using TNF drugs. There's a nice analysis just published yesterday or 2 days ago in the IBD literature. These were looking at actually natural COVID infection in people on infliximab versus vedolizumab. And what they show here is the people on infliximab had much lower antibody responses or neutralizing antibodies measured after infection. So those individuals who had similar severity to the individuals on vedolizumab, when they looked at those two groups of people, they seemed to have lower antibody responses in the infliximab group. So I happen to believe that probably infliximab is protective against more severe progression of COVID or COVID, or SARS-CoV-2. And I thought, well, maybe this data is confounded by the fact that people on infliximab maybe had less severe disease, but they actually did control for that, and they did compare people with similar disease severity. So there is again another idea here that the infliximab might hinder antibody responses to the natural infection, and therefore we would worry about the vaccine. Methotrexate, we know holding methotrexate, at least in 2 studies, has been shown to improve the humoral response to influenza vaccine. With tofacitinib, we have influenza data and pneumococcal data, and they're both very similar. Tofa and methotrexate seem to decrease responses, and again, really quantitative responses. The percent of people reaching kind of seroprotection seems to be about the same. It's a little bit lower, but about the same. But you can just look here on the right, the data with H3N2 after influenza vaccination. The placebo group had much higher geometric fold rise in their titers as compared to methotrexate alone, tofa alone, or the combination. So again, I would expect probably patients on JAK inhibitors are going to have some diminished response to COVID vaccination. And then rituximab, I don't really even need to show you the data. Ritux annihilates humoral responses. And there's no question in my mind that the patients with recent rituximab use will have diminished COVID vaccine responses. Tocilizumab, IL-6 inhibitors, the data there is with flu and pneumococcal, and the black bar are people on tocilizumab. They actually had better rates of seroconversion than the comparators in this study, which were healthy controls or people on methotrexate with or without TOS. So there wasn't a sense that IL-6 inhibition would diminish vaccine responses, at least from those vaccines. And lastly, IL-17 blockers, again, one study, very small, using healthy controls, but no diminishment in vaccine response with influenza. So that's the soapbox tree where that adjuvant comes from. What do we know about Shingrix? Not a ton yet in this setting. We're studying this actively, as are others. This was data from the Calabrese's at Cleveland Clinic, but they did show that the patients with primarily RA, but other forms of immune-mediated inflammatory diseases were more likely to flare with that vaccine. And again, that vaccine has the same or similar adjuvant as the Novavax COVID vaccine. So, the idea that some of these vaccines may flare underlying autoimmune disease, again, is something we need to study in the context of COVID. And then this is the last thing I'll say about JAKs. Very intriguing data. It's preliminary. It was presented at the last ACR, but showing that there was this group of people here that just did not mount any sort of antibody or humoral response to Shingrix while they were on a JAK. So a lot of people did, and you can see the lines going up here on the left, and you can see the healthy controls on the right going up, but you see these flat lines that went across. There was like about a third of these RA patients did not seem to mount any response at all. So I don't know if there's just something different about them, or maybe this is a mistake and we're going to see in the final publication something different. So, but it is intriguing, and I think there's other data that suggests there are subgroups of people that don't respond to that vaccine. So I'll just end here with the ACR's guidance. So ACR, so I'm on the vaccine guideline committee at ACR. We convened a task force to work every day through the holidays, so we didn't have to. Just kidding. But to consider all that data, I was just showing you plus more in terms of what do we know about DMARDs and how they affect different vaccine responses in our patients. And from that, this extrapolation was made, and an expert opinion document was put forward in terms of what you should do if someone's DMARD in the context of COVID vaccination. Again, this is a living document. It'll be updated constantly as data starts coming out. And we're now starting to see a little data. There's a few case reports out there about people not mounting good responses who are on drug X, Y, and Z. So we'll have to see where that all goes. We're actually doing a large study in collaboration with ACR and a number of other sponsors, where we're going to test some of these recommendations specifically to see if they make a difference in terms of immunogenicity and perhaps even efficacy if we have enough power. But those ideas center around temporary holds of methotrexate or a JAK inhibitor, or considering skipping a dose of abatacept, for example, and really waiting as long as possible to vaccinate after rituximab. But the question is whether these hold strategies would be worth doing. The risk of an RA flare when you hold someone's JAK for a week is pretty low. My personal opinion is if I was going to hold a JAK for 1 week, I'd hold it for 2 weeks at the time of vaccination. But anyway, these are things that need to be studied, and we'll go from there. So with that being said, I'll stop and take any questions, or I guess we're doing questions later. So thanks. Thanks
very much indeed, Kevin. That was terrific. Much appreciated. So we have a moment here just to take a big deep breath, and then we're going to bring Rika in. I think we lost the slides, at least I did on my screen. So maybe one of our brilliant technical gurus can return them to us momentarily. A lot of questions coming in around vaccine, and a lot of that, it has to be said, coming in the area of scheduling. And what I suggest we do is, Rika, we bring the management talk that you're going to give us up now, and then when we've got that together with the vaccine questions, we can take it in a oneer, because I rather suspect the two are going to overlap. So Rika, it's a real pleasure to welcome you and bring you into the forum, and look forward to learning of your thoughts around the management of patients during this pandemic. To you, please.
Ian, thank you very much. I'm moving forward with managing the patient during this difficult year. And I want to cover some points, not all. there are guidelines which were mentioned already by Kevin. What do they help us? What is the need of them? And of course, how the clinical daily practice really changed. If I go to the waiting room today in my clinic, it is much more empty than it has been 1 year before. And sometimes patients go away and say, is something wrong? And there's no doctor there. So, and then last but not least, I think I want to point out the big information we got from our registries, not only local, but European and global. Let's start. So mentioned already, the coronavirus disease treatment guidelines from the NIH were very helpful. And as you said, Kevin, it is a living document. And we can see already here that we have already version number 3, which was just published some weeks ago. And these guidelines are very often updated. They are also helpful for Europe, but some of the points are only covering the specific situation in the United States. So this is why we need also other guidelines. And what I appreciated most in my preparation for this talk are really the guidelines from the NIH and the British Society of Rheumatology. They are very practical and very helpful for daily practice. We should avoid unproductive attendance in the hospital. Also, there should be find out new ideas to do work outside your subspecialty. I gave 3 of my doctors during all this time to the COVID area, and they really helped out very much. And again, in the wave number 3, which we have now, I was asked today by a colleague whether I can help out with other doctors. And this is very, very important to have the flexibility. If you are a neurologist or if you are even a food surgeon, you can help on the ward with the COVID patients. If you have a good teacher there. And what we also learned that we have go back again to 7-day service. And what we did, especially in my unit, we wrote a letter in March, in the end of March already, in the Easter break last year, to all patients. And we tried to postpone long-term follow-up visits, which were not necessary when we went into the details of the disease activity. And that was really helpful. And we had many feedback from the patients. So really, we should look to remove the need for patients to attend face-to-face appointments whenever possible. This might involve telephone appointments or video consultation, which we all installed in this year. And by now, we have a very nice survey done by our German Society of Rheumatology, how many really rheumatologists changed to video appointments from the year 1 before, and learned a lot by this. And what I also appreciated is I had a memory a little bit of the OMERAC group where I worked, how patients can self-assess their swollen and tender joints when we studied the flare. Because this is, I think, really an important video. And then the patients can report back how they feel, and they can give us really concrete information on the situation of their joints beyond only subjective feelings. This is very good. So self-assessment, this is also something which will be in the future more and more important. And especially if we have more apps like the Remora app, which can record patient-reported outcome, not only swollen and tender joints, but also fatigue and other points to consider when you are going to have a concrete wording for disease activity. Patients can be very helpful for this. So as I said already, minimize the face-to-face contact and really offering telephone or video consultations and contact patients by text messages. Patients like this, and they really answer normally rapidly back. And you need, of course, many help in your institution. You can't do this all only on yourself. But the nurses in my unit really took up very nicely in the last year and helped us a lot. Today, I had 1 hour talk with the nurses, and they really contact the patients. They ask how they feel, and they give very nice feedback on their work. So this, I think, is very practical, but it's so important. We have some Turkish patients and also patients from other areas. And for them, coming without a family member is very difficult. And what we teach the patients, use your own transport and try to travel alone. And do not arrive early. We send them always out. Now it's easier because it's not so cold anymore. And while you are waiting, we are texting you when you are come in exactly. We have a careful scheduling also in our unit. And of course, we saw less patients in the clinic than before. So the German Society, coming to that, has a full program on working on COVID. They gave every month, starting in February last year, a very nice information to all rheumatologists to really give good guidance to their patients. The last information they gave us some weeks ago is on vaccination. And now we really could also write some medical charts to give prioritization to our patients. And that worked nicely because especially in Berlin, for instance, nearly all patients with rheumatic diseases got vaccinated in the last 4 weeks. That is really a big advantage due to this certificate we could give to our patients, which was not the thing before. Now coming to registries. There are some registries, they all work together. The COVID Global Registry, Rheumatology Alliance Registry, has collected most of the data. And by March 1st this year, there were more than 6,000 data sets collected, most patients with rheumatoid arthritis, many patients with comorbidities, and also the medications were typical methotrexate, etc., etc. This is not new data, but it delivers the foundation for all our conclusions we can take later after the pandemic. This is one nice paper which was published by my colleague Anja Strangfeld and the German working group on the Global Alliance paper. And what we saw in this publication, and there were some correspondence or again in Annals of Rheumatic Diseases, that of course there is a strong interaction between the glucocorticoid therapy and the disease activity also of the COVID infection. And this is important because we have also other information, of course, but for us in Germany, the high dosage of prednisolone is really not good for all our patients. And the control of disease activity by standard DMARDs or TS DMARDs is so much more important than just giving prednisone to the patients. So the EULA COVID database, I will rush through. There are many informations also on diagnoses, on the symptoms, and of course on the cause of the disease, but they are much in line with our German registry. We have collected last week more than 2,000 patient data, and you see here already the increase in the last months. And how are the data collected? They are collected all over Germany, all over the German federal states. And when you can see the conferences by our nice Chancellor Merkel every second week, then you can see how she is struggling really to convince all the presidents of these German federal states to follow her recommendations. And if we would have followed her a little bit earlier, maybe the situation would not be so bad as it's now. The distribution by age and gender, typical female patients, and even the age is interesting because the age group between 50 and 56 is the most represented group. We can see here again, as in the other registries, of course, most patients with rheumatoid arthritis, but all other diseases are also represented. Most patients are on methotrexate, but what I was really astonished when I saw these data of the last week, many patients are still on prednisone, despite the fact that we have very strong recommendations that after 6 months, every German patient with rheumatoid arthritis should be off steroids. That is the reality, and the other thing is the recommendation. So here are the data concerning the infection status. Most patients recovered, but we have seen also some patients who got lethal outcome, and that was mostly these data collected in the first months of the last year. The lethal outcome has much diminished in the last months. You can see here again data on the outcome, and on the next slide what has EULA given us? And Ian, you should know this better. I heard that the EULA provisional recommendations for the management of COVID and rheumatic diseases is under review and will be expected soon by Robert Landaway. But there are also other important publications which we have. I just have to make it a little bit more bright. Okay. Next slide I will show to you. Did I lose control? No, I did not lose control. That is the paper by Alessia Alunno, also published shortly in the Annals. And these are the points to consider on the pathophysiology of the COVID. And I think the point number 13 is very important. The patients with COVID-19 requiring ventilation or high flow oxygen, the combination. And we have seen this already in the nice talk by the colleague from the NIH, with Remdesivir plus Baricitinib could be considered, since it can decrease time to recovery and accelerate improved in clinical studies. We have seen many patients, by the way, on JAK inhibitors in our clinic during the pandemic over Christmas. But for them, the stop of the JAK inhibitor has really negative effects. So they came very early at the end of January when they recovered and asked really desperately to move on with their JAK inhibition therapy. That is really a new experience we have. So our daily clinical practice has been changed profoundly. I think the possible reduction of face-to-face contact and the introduction of remote consultations would not have been imagined in the early 2020 or in 2019. The global registry data have shown that people with rheumatic diseases with higher disease activity have higher odds of COVID-related deaths, highlighting the importance of disease control, preferably by managing with DMARDs effectively without increasing the glucocorticoids. I think that is really very important and the most learning we have had from this year. Future studies should address the observed association of rituximab and also sulfasalazine, because there are also new data, and this is widely used. If this could be related with poor outcomes, especially as we every day have patients in the clinic with the most severe diseases on Rituxan. I saw 2 patients today and I had a long discussion for them on the vaccination and the right time point between the 2 infusions. And this is a very, very important point, I think. And what is also important for us is that we take into consideration that the comorbidities of our patients are really well managed, not to increase their risk of a lethal or fatal outcome. So last slide, the clinical trial registered trials, clinicaltrial.gov, you can see here, and this is what gives us also hope that more than 5,000 trials are underway. And we can see that we are really will have new evidence and new data when we are a little bit more far advanced with these trials. And one trial of the University of Alabama, I think, is very interesting. It is just started, especially taking the investigation how really the new techniques change daily clinical practice and how it will be changed in the future in the next years, especially in rheumatology, where a lot can be done also remotely. Thank you very much.
Thank you so much, Rika. That was fascinating. And I have to say, a very comprehensive overview of what is an enormous subject when one stops to think about it. So, well, thank you to all 3 of our faculty. And thanks to you also for putting in so many very nice questions indeed. As I promised, I'm going to give all the hard questions to our brilliant faculty. And if there's any easy ones in there, I'll pick them up and be sure to try and look impressive. But let me start with a couple from our audience already. Let me start, and maybe Kevin, although John, you may want to comment as well. One of our delegates has asked, what do we feel about the spacing out between the initial vaccination and the boost inactivation. You know, there are some countries, and I couldn't possibly name them, but I'm living in one of them, that would be the United Kingdom, where we kind of made a decision to vaccinate a lot of people with first shot and then delay the second shot, maybe up to 12 weeks. Any thoughts about whether that will impact long-term protection? Because it's an interesting balance, isn't it, between the public health good, the greater good, against that individual who unfortunately didn't mount a sufficient response. And there's a follow-up, but let's maybe, Kevin, have a go at that to start with, and then John, I'll maybe ask for your views also, please.
Sure. I mean, I guess my answer is más y menos, like it doesn't matter. That's what my real answer is. And I think, you know, in terms of the individual, you know, if you get your booster at 4 weeks, or if you get your booster, you know, 8 weeks, it's going to be just as effective. In fact, maybe it'll be more effective if you give it slightly later. You know, what's the risk? The risk is that you're, you know, running around for an extra month with a lower level of protection. So what level of protection do you have? It's probably somewhere between 50 and 60% after one shot, at least with the initial trial data released with mRNA vaccines. And you've seen one-shot vaccines now that are like the J&J vaccines, one shot, and the efficacy is in the 70% range. Now they have a 2-shot trial. I'll bet you it looks better, and that everyone who got one shot is going to be advised to get a second shot sometime later. So we'll have to see. But you know, I think, you know, we obviously chose not to do that here because in the US, we're by the book. We do what the label says. And I don't know. I think we had enough vaccine supply that people weren't tempted to do that, but you know, the race against the rise of the variants and trying to, you know, we're entering this third and a half or fourth wave or fifth wave, depending on where you live, and you know, it's not a bad idea to try to vaccinate more people as quickly as possible. I mean, it makes sense to me. So I think if you're living in a place where, from a resource standpoint, you know, in terms of vaccine supply and giving the vaccine out, administering it, that's easier to do. It seems to be a reasonable decision. So I thought the UK's decision was pretty reasonable.
Thanks, Kevin. John, anything to add to that?
Yeah, I would frame it slightly different. I mean, I don't disagree with Kevin that it's a reasonable approach. I think at the end of the day, we ultimately have to stick with what the data shows. And the data was 3 weeks for Pfizer and 4 weeks for Moderna. Anything outside of that, you start seeing separation of the curves of infection early, but I don't think we have confidence in in understanding how effective that vaccine is. So it's not that we need to be adherent to the label, but I think we need to be respectful of the data and the science, and I think that's why the position was stick with what we know works.
That's a fascinating remark, and maybe just I'm pulling together several of the questions that have come from delegates and indeed my own curiosity. First of all, impact of emerging mutants on vaccine effectiveness. Now, I realize there's a little bit of kind of molecular Russian roulette about that, but what should we say to our patients when they come into the office tomorrow and say, look, I'm worried about this variant from Glasgow, yeah, just for want of a better place for it to come from. You know, what is the likelihood that the vaccines will be worked around by the virus? And what, if anything, should we be saying to our patients in the meantime? Maybe John, to you, and then back to Kevin. And then Rika, heads up, I've got a couple of questions for you in a moment. But John, it's a really difficult one, I know, but your best guess would be appreciated.
Yeah, no, Kevin actually laid out the data that we know, which is the drop in neutralizing titer. And we started such a high titer for all these vaccines that even the 6-fold drop that you saw with the South African variant seems to be at a level that we think is above what's necessary for protection. Now, we don't know correlates of protection yet, so that's one of the big gaps. And hopefully in the next few months, we'll be able to answer that question. I think, to be concrete, the strains circulating in the US, the strains circulating in the UK, the majority of them seem to be easily neutralized by the current vaccine. The ones coming out of Brazil, South Africa, it's a big drop. We think it's protective, but we need more work.
Yeah, thanks, John. That's a really helpful answer. And Kevin, I don't know if you want to add to that, or it seems to me that we're right on message there.
Yeah, no, I agree with John completely. I think it's the great wild card. I mean, I'm very optimistic at this point. I mean, at least in our country, I think our vaccine rollout is going extraordinarily well as of the last couple months. And, you know, I feel like I'm going to be back to normal in the fall. But I also know that that a new variant could come from Glasgow at any moment and wreck that dream. So I do think it's something we need to have good surveillance for. And, you know, we're starting to do better with that as well. And obviously we can react to it if needed. And you've seen some of the vaccine makers have already gone back, right? They're already remaking a few of their vaccines to cover potentially, you know, current mutants as well as other, you know, future envisioned mutants. So I think that the beauty of the vaccine, and particularly the mRNA construct, is it's pretty nimble, and they can probably get something else out really quickly if we need it. So. And you know how that would play out with regulatory and all that would just be something to think about at this point. But I do think we have the ability to respond fairly quickly now as compared to earlier. So,
Kevin, you made a very interesting remark there. There are many reasons why I counted you as a friend for many years. One of them is your optimism, and I want to just say that the public health messages, I don't know what is like in the US, but certainly in some European countries, the public health message has been very pessimistic about when we're going to come through this. And that is creating a state of understandable anxiety on the part of many of our patients. Maybe Rika, could I come to you just from the management of rheumatic diseases? How are you managing the concerns that our patients feel about, you know, will my medicine, you know, Kevin's given us a few advices on how to adjust that, but you know, will my medicine continually be a problem for me? Am I more at risk? I'm more afraid than my neighbor. How are you dealing with that in your clinical experience? Because it's a question we're all being asked very regularly in practice.
Thank you very much for this question. And what we learned in the last months, that we have to be very more open to all the questions of our patients than before, and to find out also new methods of communication, like letters to our patients, and to summarize the most important questions they have. But what we did is that we were really teaching the patients that a stable disease activity and not a high disease activity is the most important goal for them. And this also for the price of not stopping any therapy, except, of course, what we were telling our patients, and we gave them calls for the Rituxan patients. Only the very, very heavy diseases like angiitis or whatsoever, they needed it. We really postponed the next infusion. And what is also important, that our patients got trust from us, and a more optimistic way. You know that we had many messes in the last 6 weeks with AstraZeneca vaccination in Germany. That was in, out, age group was changed, etc. And that was really, we got many questions from the patients. What shall we do? Shall we take AstraZeneca? Shall we not take AstraZeneca? And that is not a very, very good political decision, which did not help our patients. And in the end, the most important message was concerning vaccination. Any vaccination is better than no vaccination for our
really
patients.
Hammering home that point, Rika, that you make, but just allow you to emphasize it. Glucocorticoids especially are something that we need to be looking out for. I mean, if there's one take-home message from this webinar to every clinician listening, and thank you, by the way, for joining us from so many parts of the world, it is that glucocorticoids are a red flag. Is that a fair summary?
Absolutely, absolutely. And this came out again by the research of the German Research Center by Anja Strangfeld, and which we collected the data in the rabbit registry for many years already. And I was really a little bit pessimistic when I saw the data that so many patients are still on prednisone above 7 milligram. And that is really bad.
Yeah, I have to say, I debated with John Stone at an ACR meeting a year or so ago the merits of glucocorticoid use. And I have to say, it was the dependence we have as physicians in the rheumatology space on steroid in this day and age is quite depressing given the other options we have available, but enough said. Okay, look, there's quite a lot of questions that come in. I'm going to group them into one general question, and it's about how safe are these vaccines? So to many of you have asked quite specific questions. You've asked about thrombotic risk. You've asked about idiopathic neuropathy development. You're asking about whether there is a particular risk of failed efficacy in immune suppressant pregnancy and the like, particularly if there's a delay in second boost. But maybe first of all, to Kevin and then to John, please, your thoughts on the overall safety, any red flags for us, and then maybe, Kevin, if you could do that, and then John, maybe have a think about a sort of a take-home response. What should we be saying to our patients tomorrow when they ask us, is it safe or is it not? But Kevin, your thoughts, first of all, thrombosis, idiosyncratic immune reactions, you know the list. It's a long list.
Well, I would just start off by saying my general comment is these vaccines are remarkably safe. They've been in millions of people. The number of serious adverse events is unbelievably low. And there's not one event out there that would preclude anyone from wanting to get the vaccine or should preclude them from wanting to get the vaccine, given the risk benefit. So that's the overarching comment. I mentioned reactogenicity in my talk. That's the short-term consideration is common. In terms of serious adverse events or kind of more serious adverse events, I mean, we've seen some Bell's palsy with the mRNA vaccines. There's some interesting reports of people actually flaring shingles after their vaccine. I had the gout attack after my first Pfizer vaccine that was unbelievably painful. I haven't reported that in the literature yet, but I'm reporting it now. And it was the worst pain I've ever felt in my life. There are issues maybe with the adenoviral vaccines, the AZ vaccine, the EMA, and obviously the UK. People have come out formally those agencies have come out formally in the last couple days, and the German health agency. And I do believe, after looking at the data they've presented, although it's only in press format, there's a number of cases there that the risk seems to be only in younger people. It seems to be, and this is with this like DIC or systemic coagulopathy like picture, often with low platelets, so platelet consumption. I mean, I don't understand the pathophysiology. I don't know that anyone does, but it seems to be a real side effect, and it seems to occur in the 1 to 300 or 400, 500,000 range. So it's pretty darn rare, but it is real enough that I think it's reasonable based on the data I've seen so far that they, considering limiting the vaccine in younger populations, favoring other vaccines in younger individuals makes sense. And that's what Europe has done. I mean, I think France has drawn the line at age 55. They're not using that vaccine in people under that age. I think the UK, maybe you guys said age 30, and I forget Germany. I mean, there's been kind of this consensus that if you're old, it's okay, but if you're under a certain age, maybe take the other vaccine. So I guess I'll leave my comment there, but I do think it's probably real. And I think the anaphylaxis issue, that was the other issue, particularly with the mRNA vaccines. I mean, it's probably real, but I don't think it occurs at a frequency that's any different than, other anaphylactic problems, like people, I don't know, getting stung by bees or eating peanuts or getting hit by cars or whatever. I don't think it's a super rare event. So, but if Pfizer's studying it more, FDA is studying it more, it makes sense to do a special study in people that have risk factors for that to see if it's a true vaccine related issue.
Thanks, Kevin. John, anything quickly to add to that? That's a really comprehensive answer, I must say. Thank you.
No, I mean, I agree with exactly what Kevin said. The one thing I would add is just an emphasis to change the narrative that this was a vaccine that was developed quickly. I mean, this is a vaccine that's been developed over a decade of research into the spike protein, multiple constructs of mRNA vaccines. This wasn't something that was turned on in January. And there's this narrative out there that how can it be safe? It was developed in months. It wasn't developed in months. It is a long, thorough process that set the stage to be able to respond quickly.
Yeah, I think that's the piece. And the take-home message that I'm hearing from our delegate panel, our faculty panel, it's certainly the message we're giving out is that the relative risk to you of a vaccination is considerably less than the relative risk to you being in a population unvaccinated with circulating virus. It really is as simple as that. And I think that pertains even if our patients are taking immune modifying medicines. That the question then arises is how effective that is. And the other piece that I think I'd like to highlight for our delegates is that at the moment, we don't have a blood test that says you're immune or not. That's what patients ask. They say, can I get a blood test to tell me if I got enough antibodies? And the problem is that, and if that was that remark you made about, protective correlates, that's a work in progress. And it's very important that we don't mislead our patients into saying good antibody, good protection, go out and party all night. That's the worry, is that people make that mistake. And yeah, you're right. MHRA issued warnings today. 30 is the cutoff here. And there are some concerns, particularly about patients with phospholipid antibody, where not to use the AstraZeneca vaccine. That's now been defined, at least by MHRA. So, and that picks up one of the other questions as to whether, and maybe Rika, you want to handle this, but any particular parts of the immune-mediated inflammatory disease spectrum that we should be especially worried about? I don't mean the rituximab recipients, but more for the development of an adverse event. Antiphospholipid antibody seems like a relatively obvious problem for us to be thinking about, even if it may not be the right antibodies that are causing the problems. Any thoughts?
Actually, if I see patients who are ACPA positive and smoking and taking oral anticonceptives, I invite them not to take AstraZeneca at the moment, because this would be a higher risk of, as we know, that smoking and ACPA positive is already a risk per se for complications. But coming to diseases, I think the antiphospholipid syndrome is one, but maybe certain types of vasculitis could be risky with low complement, and also maybe thrombocytosis problems, etc., etc. So that could be also a concern.
Rika, thank you so much, and thanks to all of our delegates. I'm afraid we haven't been able to answer all of your questions. We've covered a pretty broad range of them, and we've covered matters of real clinical importance. And thank you to my colleagues in the faculty for making such clear and erudite responses. We are required to finish our webinar in about a minute's time. Let me summarize for you what I've heard. I've heard that this is a disease which is indeed a systemic inflammatory disease with a viral trigger. We've learned that the appropriate use of immune-modifying medicines, highly specific immune-modifying medicines, appropriately timed, may well bring about reductions in hospital stay. We hope in the long-term reduction in mortality, but we've also had highlighted by John the real challenges in designing the right trial. What is the right trial timed at the correct point in such a complex and heterogeneous disorder? That, of course, has resonance for us as rheumatologists who've been trying to design the right trial for multi-system complex immune diseases for many, many years. And the right sequencing, I can tell you, John, is still very elusive for us, even after 2 decades of trying to use the right medicine at the right time in the right order. We've learned about the incredible progress made in vaccines and the overwhelmingly reassuring message that we should be using these vaccines in all of our patients with some judicious amendment of timing of the immune modifying drugs that we have. And we would recommend that you look at either the ACR or EULAR advices in this matter, or indeed those from national guidelines for adjustments, subtle changes. But of course, that's been balanced with the highlighted need that Rika has brought to us for maintaining proper disease control. That, above all, will diminish the overall risk that our patients face should they be unfortunate enough to contract SARS-CoV-2 infection. Well, ladies and gentlemen, our time is up. We will finish in a timely manner. Please, would you feed back to us? We pay really close attention to the feedback. There's a short evaluation form. Fill it up, send it on to us. And of course, it would be lovely if you join us at the cytokinesignaling.com website. We always have information there concerning the whole of the rheumatology therapeutic field, of course, but at the moment, especially in the area of managing rheumatic disease in the COVID area and COVIDs in the context of management. So I'm really grateful to our faculty, to Rika, to John, to Kevin for sharing their expertise with such clarity and in a time of really rapidly evolving literature. I don't know if you noticed 5,000 clinical trials. I had to Google last week. We're currently up at 130,000 publications in PubMed. Our faculty read every single one of those papers. Well, almost all of them in the preparation of this webinar. But finally, ladies and gentlemen, to all of you, thank you for joining us. Thank you for looking after our patients in these challenging times. And for me as the chair, it serves only to wish you safe times, healthy times for you and your loved ones, and of course, always for our patients. Thank you very much indeed for your attention. Bye-bye for now.
Thanks, guys. Nice to see you. Cheers. Bye-bye.